Welcome back to this bonus content edition of Clinical Communication, where I'm giving you some additional content from recent guests that didn't come out at the time, but hopefully you'll find useful for your clinical practice with a variety of patients that you may see. If you find this useful, please do go and share it with others. Please do subscribe, and please do send in any stories, questions, or suggestions to clinicalcommunication@outlook.com. We're going to start this one with the most recent guest, which is Matt Wedderburn, where we talked about communication challenges in first contact practice. And in this bonus content, we're talking about when and how you should ask ICE questions when your time is limited, and if we should bother using a body chart when you don't have much time. My belief about ICE questions, I normally put mine at the end, but I have a lot of time with people, right?
Hmm.
You don't have as much time compared to I do. And my suggestion was always, if you don't have as much time, put it sooner. What's your thoughts on if you have 20 minutes, if well, 5, 10 minutes for subjective, when?
I think it's tough. It's a tough question because I truly believe you can ask them whenever you want to ask them. The one thing I would say is ask them together. Don't have them ideas at the start, concerns halfway through, and expectations at the end. I would group them together in terms of when you're asking those questions because it helps to maintain the flow of the consultation, which is something that you key of. Personally, when do I ask it? It can vary, but mostly would be after I've done my open-ended questions, done a bit of red flag screening, then I'll get to the crux of, okay, what what do you think's going on? I'd be interested to know, and then just sort of take it from there, really, and that will roll nicely into what worries you about that, and then again, what you're hoping from me from this consultation. So, yeah, I think you can place it anywhere within the consultation as long as my thoughts are ask them together to maintain the flow. And as long as you do that, you should be fine.
Most do most people does anyone ever get upset by being asked?
If you
Uh,
ask them wrong, yeah.
yes, that's
If you ask
true.
them wrong, yeah, yeah.
Yeah.
If you ask them wrong, if you just say, I mean, I've had it before, especially when probably earlier on in my career when I was being told you need to ice people, and you ask them, and you can be quite blunt with it, and you get the typical response that everyone will say, "Well, you're the expert." I'm sure
Yeah.
we've all heard or had that before, or heard someone tell that story before. So yeah, how you ask it is really important, and I think that's one of the big things that it's not hard to do. It's not hard to ask it right. It's knowing how to do it essentially, and being guided on doing it correctly. So I always sort of play it down a little bit in terms of look, this sounds like a really daft question,
Yeah.
but what are your thoughts about what's going on? Have you had any thoughts? Have you been on Google? Have you spoke to someone? And they'll answer it. They won't sort of fight back at you or snap back if you just ask it in that sort of conversational manner. From my experience, anyway, others may have different experiences, but yeah, if we ask it correctly, you typically won't get a bad response. You'll get the answers that you need from it.
Actually had an experience, I want to say last week, recently, where it wasn't just the asking, but someone said they didn't like they were the question, not because what was asked, but because how it was answered, like responded with, um, from the reaction when they said what their impressions or thoughts were, um, the reaction they got back from the body language and the tone of the clinician made them feel like they were talking a load of rubbish essentially, and it was silly. So yeah, you're spot on. I think it's as you say, how we ask it, and then what we do with it as well. Because there's no point asking if you not actually care about the answer.
Exactly, exactly. A lot of people use it from my experience doing supervision, is a lot of people use it as a tick box exercise, either
Mm,
because they've told they need to do it or they need to pass some sort of audit and to show they've asked the questions. But you've got to want to understand and you've got to care
yeah,
to ask the questions, or else it's pointless asking them essentially. And like you said, the body language that you give off is, I mean, we know that a large part of what patients will go away remembering is um, the way you say, like how you say things rather than what you say and the way you make them feel. So you've got to be mindful of the non-verbal communication side of things, because
Mm.
that's massive, and it can be quite easy as a clinician to sort of sit on your high horse and a patient say, I think I need an MRI scan, or I think it's this and that, and you just sort of shrug it off or have a little bit of a huff and think, well, you're totally wrong.
Mm.
It's not helpful for anyone,
No.
and you're probably going to send the relationship crashing down, which is definitely something you can't do in a 15-20 minute appointment in FCP anyway, so never
Mm.
mind sort of any sort of clinical consultation really. So yeah, you've got to be really careful, but you've got to care when you're asking them.
Yeah. The other thing I want to ask with a short appointment, what about the body chart? Should we spend if you've got limited time, 3, 4 minutes with your little red colour going down the line on one leg and the arm on the other, and then some dots for green number and all that jazz? Is it worth it, or is it better just to write in your time
To
limit?
be honest, Ben, I can't remember last time I used a body chart. Very, very rarely use the body chart. I know it sounds mad, but
No, no.
to me, my mind sees, I picture it better written down. So where it is rather than looking at a picture of a diagram. Um, I've only ever done it really if it was required. So yeah, I would always write it down because especially if you're, let's say if you worked as an FCP, Ben, and I had to go back and look through your notes, and rather you saying where the pain was, I had to then click on a separate image to try and find
Mm,
it. It just adds work to it. Everyone's going to know what you mean when you say left posterior thigh.
yeah.
Don't need sort of the hash drawings on there, spending 5 minutes or whatever it takes.
I don't know. I don't actually know many specialities that use it, the body chart. I was thinking the other day, looking through like hospital notes of other patients. I haven't seen orthopedics use it. I haven't seen rheumatology or any other bits use it. There's the odd one, but I don't know why we decided to pick it up as something initially do in our subjectives to write down. We could just, as
Got
you say,
no
write
idea.
it.
Yeah, I've got no idea. But some people like it. Some people prefer those sort of visual cues and seeing that, and it makes more sense to them than how they might describe it written down. But yeah, I'm not against people using it, but generally, I've never used it in FCP anyway. Never used it in FCP. Well, I'll tell you what. I'll tell you when I have used it for the diagnostic worksheet. That's when I have used it.
Oh,
But there's a little body chart on there, and it's
yeah.
only because I've printed it off and I'm just sort of showing the patient, right, where is your pain, and I'll just sort of get them to do it even though I know you've got the little tick boxes underneath on that worksheet, but that's probably the only time I've ever actually used a body chart in clinic.
That's the one time I don't use it.
There you go.
I'm like, because my question is, do you normally to them? If they've come in with fibro, they typically have widespread pain. So I normally ask them, is there anywhere you don't have pain?
Yeah.
Um, but yeah, and I can't, I'm not going to spend 5 minutes just colouring in an entire body chart, am I? That'd be, and how's that going to look? Like the patient's watching you colour their entire body in red.
Yeah.
Up next, we have bonus content from my conversation with Ben Steele-Turner, where we talked about how to discuss weight management with the patient in front of you. And in this bonus content, we're discussing how you can get buy-in from patients with knee osteoarthritis to think about weight management and how we can make weight management plans that last. Okay, the first of these two bonus questions is how do we get buy-in for weight management for knee OA? So we've got someone with knee osteoarthritis come in to see us. You want to discuss the weight management with them. You know it's going to help them. How do we help them believe it's going to help them?
Yeah, it's really interesting. I'm talking about this in the sense of in the context of a healthcare appointment, right?
Yeah,
So
yeah,
the key thing is we've got to relate it to the issue that the person is there for. So when I speak about this, and my thoughts are, if you're a physio, we're both physios, but any healthcare profession, if someone comes in and they are living with overweight and obesity, but they have rolled their ankle, and you can see, objectively they are have an elevated BMI, you're not really in any remit, I don't think, to bring up weight management because the reason they have come to see you is for their rolled ankle.
yeah.
Whereas with someone who's got knee OA, is like there's a really strong rationale for why we're bringing it up. So the buy-in, and in the literature they would say we're giving them a medical trigger. So we're giving them a clear rationale and education of why. So the you're clearly linking this is why we should maintain a healthy weight or try and lose weight. And it's because of the reason, you felt motivated enough to attend this appointment because of X issue. And if we look at the things you can do, I know for the scope of a physio, you might have expected me to show you some straight leg raises and some bridges, but actually this is what's most important. And I think that's how we've got to get the most buy-in, is really linking it to they've already been motivated to attend the appointment. You're just trying to show them the best things that the evidence show can help address the reason they've attended the appointment. So that's how I would go about getting their buy-in.
I think that's important there, because you're pointing out how they've already made the start of their journey by turning up. So they're already on the journey. So if we can, there's some form of behavioral science about if you can show someone they've already started something, they're more likely to then keep going.
Yeah. Yeah.
And so I guess you're saying you've turned up today is them already on the journey, right?
Yeah. Unless they've been forced to attend. But, normally we would say, like, if they've given their implied consent, i.e. they have driven themselves to the appointment and they have walked into the room. So they've implied that they've consented to hear. They're motivated to treat. When you've asked them what the issue is, they've discussed their NEOA. So this kind of seems the best buy-in in that context, I would say.
Yeah. So let's say you raise it with the person. We'll come on to how to do this a bit later. But you raise it, they've got the idea. I guess you point out that they've already arrived, already turned up to discuss it with you. They're open to discussing it, open to making a plan. How do we make that plan that will stick? Because you hear lots and read lots about people that start weight loss or weight management plans, and it starts great, and then inevitably it stops, and then they can reverse back. How can we make one that sticks?
Yeah, super gradual and super personalized. So difficult to talk about in overarching, but I'll give my best idea I can. The key thing is not the little indices of, do you know it's really important of reducing your calories by 100 or whatever. That stuff's important, but that stuff can be delivered quite compact in an educational format. It's in the same benefit that I would always say with a physio, when you give someone a good rehab plan and you say, right, in 2 weeks, you're going to come back and this is your goal on that single leg sit to stand. I'd really like you to be getting 15 instead of the 9 that you got today. Yeah. It's that accountability. And this is where I think healthcare professionals, particularly physios, are well placed with this, in that we can see someone regularly, so we can set a goal. So we can package the nutrition stuff, which we can come to later, or weight particulars. But that, first of all, that accountability of like, right, here is a set date, and on this date, you and I are going to meet again, and we've talked about X, Y, and Z, and I feel that this might be a good weight or good goal, or these might be some good process goals that we're going to aim to. I'm just going to pick this out of the hat, but you must have 2 portions of green veg per day every day, and gamify it. That's a little game, right? 2 portions of green veg every day. Here's a big list of 20 different green veggies. You have to have 2 a day. Whatever you do, you got to have 2 of them every day. You've got to have 3 portions of these protein sources per day, and here's a list. So gamify it. 2 of them, 3 of them. Next time you're here, we'll add on a third criteria, which is fruit. And what would be really nice is if we aim for 2 kilograms lost. And we'll go through that together. I'm going to write it on the notes. That's what I found from my experience gives people that buy-in, because then it goes the same with the physio plan. Is like, the value of them being is not maybe the 30 or the 45 minutes that they're with you 3 weeks on Thursday. It's the other 2 weeks, 6 days, 23 hours and 30 minutes that they're not with you, that the knowledge that coming up is really important. And you can just roll that through and repeat. Obviously, there's service limitations. If you work in a place where they're limited to X number of sessions, you've got to do your bit or refer to a provider or service can do that. But that's what I think's really, really key, is segmenting it down. Go, right, this is. So maybe I work a little differently, but I have a kind of a big no on set dietary plans. Like if someone just asks me to write can you write me a week food plan, which is basically a glorified Excel spreadsheet of on Monday, I want you to have this for breakfast.
Yeah.
Well, Tuesday, Wednesday, Thursday, this. Here's your shopping list. Here's the links to the recipes. Like a robot, go and follow this.
Yeah.
Because that person is only then is good to the spreadsheet. We would know from a behavioral point of view that there's a subset of people that will follow that for a prolonged period.
Yeah.
But my mantra very much is that we are a self-defeating profession, i.e., we should be, whether someone needs us 1 session or they need 100 sessions, whatever's right, we should be working to a point where we are no longer needed. So like I think James Smith years ago, he likened personal trainers to a driving instructor. Like some people need 5 lessons and some people need 25 lessons. But if you still know your driving instructor for 5 years, what are you doing? Like what have you been doing, right? And I kind of feel the same with this is as it goes, and it's one thing I really enjoy the most is when you reflect back with patients and it's like, look, when we met a year ago and I look back at the notes, it's like we were talking, like I was telling you what would count as a green vegetable. That was our conversation a year ago. And today you're telling me about this new recipe that you found and you made, and you're telling me about how you've adapted the plan, and you're telling me about how you've signed up to this new class, and you're telling me about how you found that actually the plan that we did work 6 months ago has evolved, and actually you now have nuts and seeds every day instead of the snack bar that we had agreed because it works better. And it's like this complete evolution from and so that's one thing I'm really passionate about, that we then can not make it too prescriptive. Sorry, I think I might have gone on a bit of a ramble there.
No, it's good. Is there ever a place for you're saying about the set menu, I'll call it a set menu, but like breakfast, eat
dietary
this,
plan.
that plan. And as you were saying earlier, it should be, ideally changes should be small. Like you said, 2 green vegetables to start with. Is there ever a place for the set menu plan?
So when someone's got this would be outside of my scope, but like if someone's got a particular clinical need or high level athletes, but for the scope of this, if we're talking about going through a weight management, everything's appropriate if we can in the right place. I think for a short period, maybe yes, if it's done in a very educated and the right way, and you do it to build habits. But I still would say there needs to be some flexibility in it, not just so there needs to be some way. So for example, I would say like, right, for your dinner, we might categorize it into say high carb and low carb dinners, and then the person has a list of 6 of each, and then you would say, right, and then on the plan you might have, right, so it's like high carb 6, low carb 6, and then on their plan you might have, right, on Monday choose one of high carb list, on Tuesday low carb list, Wednesday low carb list. So there's some prescription, but there's still some autonomy. I think I'm a much bigger fan of going down that route, depending on what works for that person. There are other people who are super adherent and they'll just follow everything you say, like completely to the letter. In which case, fine, as long as it works for them, then you can justify it. But it's just not really my style.
And there's also, and as you say, unless it's someone, whether it's athlete or I don't know, I'm going to say a high level, I don't know, executive or someone like that, who's just used to just being given things and just have things set out for them. Like they don't have to think about it. They have someone else to do it. That makes sense. If the person has to make the thought, then it's obviously much easier to make the cheaper, less healthy meals. It takes less effort, less mind compared to having to put the thought into them and the time it takes to make some healthy. I realise not everything that's better for us takes a lot of time to make, but it's just an extra step if they have to think about it. And also, is it sustainable?
Yeah.
the long
Yeah.
term.
So how I always think about interventions like this, and this is probably appropriate beyond just the weight management talk, is if we picture everybody's life on a massive line graph,
Mm.
and the y-axis can be whatever variable we could substitute in, and the x graphic, the x axis is their entire life, right?
Yeah.
Super long, thin graph. If we just say, right, we're going to put on the y-axis BMI or weight for right, we're just going to put BMI on the y-axis, then someone has maybe done this, or they have gradually, slowly gained weight, or whatever, and then you meet them at X point.
Mm.
The the thing that gets the line down the quickest, and the thing that makes the area under the curve the smallest possible for the smallest possible, but the optimum level for the rest of their life, are two different things. So
Mm.
for most people, wherever you meet them, and if we're talking about weight loss, so people living with overweight or obesity, and we want to just get that line down as quickly as possible, most people can do that, and with enough reasoning, or whatever the goal is, they can probably get that line down.
Yeah.
But what I would be really interested in is that we set everything up, even if that initial line is much, much of a slower gradient. We set everything up so that at some point we can say, great, and you're going to be able to maintain that much longer term.
Yeah. Yeah.
Now, for some people, absolutely, they might have, and it's completely normal, understandable. They might have their daughter's wedding in 6 months, and I want to get this line down as quickly as possible. You can't
Yeah.
knock anyone for wanting that.
No.
Absolutely not. But then that aftercare is like, you know, how are we? What's once the hangover is cleared, what's going to happen then?
Yes.
If we're never going to speak again, but in 6 months after that, your new peak is even higher than the peak that we met, then we've achieved one goal, but we probably are going to not achieve more goals further down the line.
Mm.
And from a health point of view, this is no good.
Yeah.
Um, yes, that's my mantra on it.
It's, yeah, I agree. It's set them up to succeed.
Yeah,
Um, in the long term, as you say, we don't want to be with, they don't want to, we don't want to be with them forever.
yeah,
They want them to self-manage.
yeah.
That's what all the ethos is
And,
about.
and you want things to become, um, you know, uh, 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 um, change them from being, so like the stages of learning where it's like unconsciously incompetent. So someone does something wrong, they don't even know they're doing it wrong,
Yeah, yeah.
and then they're consciously or consciously incompetent. So you make them aware, like, oh, you probably shouldn't do that. Then they
Mm.
can become consciously competent, which would be following a strict dietary plan. Like, I
Mm.
can do it if I follow this. But the
Mm.
real goal is to make them unconsciously competent, which
Yeah.
is build those habits, have that knowledge, have that understanding, so that they don't need you to be just maintaining them on stage 3 for the rest of their life.
Mm.
They can go to stage 4, and they don't need me, basically.
Yeah.
If we're talking about weight management, yeah.
Yeah. And if it's, as you say, if it's unconsciously competent, they don't even have to think about it
Think about
to
it.
make the
Yeah.
effort. It just becomes automatic, like you would if you learn to drive, right? You
Yeah,
eventually
exactly.
become unconsciously competent
Yeah.
because you learn. Up next, we have bonus content from my discussion with Mathilde Kehler, where we discussed how to coach and support someone with persistent pain. And in this bonus content, we're discussing what kind of person may make an effective pain coach. There we go. Right. Here's your starter question. And I like to think a very easy question, and I'll contribute as well. What kind of clinician do you think would make a good pain coach?
What kind of clinician?
Yeah. Whether it's personality, how they are,
Hmm.
mannerisms, stuff like that. What kind of type of person from your experience and coaching other pain coaches, have you seen make a good pain coach?
That's a good question. Thank you. Well, I think when I teach pain coaching, I talk about three things.
Mhm.
We talk about I try to make it as a Christmas tree, actually. We have this core, that is the knowledge and the know-how about pain science and all we need to know about how we understand pain today. And then we have the star at the top of the Christmas tree, which is the mindset. And that's actually quite important. And then we have the branches, which is like the skill set. So to be a good pain coach, you need all three. You need to have a very fair, good knowledge about how we understand pain today, the biopsychosocial way, but also, really this multifactorial way. Is it multifactorial? Is that how you say it in English? Can
Yeah,
you say it?
multifactorial. Yeah.
Multifactorial. Yes, thank you. Sorry, I'm Danish, so sometimes
That's all right.
I try to say that I'm in English, but sorry about that if anybody's listening. But and then you also need the skill set, right? It's just like, how do I say it? And in the beginning, you practice like a script. You have to practice the things very functional. But the most important thing, I think, is the mindset, because we can learn all these scripts, we can learn all these protocols, we can learn all these questions, but the mindset about it is probably one of the most important things to make, as you said, who makes a good pain coach. And I really think that good, I'm not really a fan of the word good, maybe, but a very person-centered pain coach, which is quite important of the pain coach mindset, that is really person-centered. So we really, really, really accept the fact that we are not the experts of everybody else.
Yeah.
But it really is the person in front of us who is the expert in their lives. And our role is not to fix them or correct them or be right or be wrong, but more to understand who they are and how they see the world, and figuring out where do you want to go and what is standing in the way of that, and how can I help you with that. So I think the mindset of it, because you can ask all the questions, but if you don't have the mindset about it, the conversation gets filled with conflict most of the time, often, or resistance, I would say. So really having the mindset of being very person-centered is definitely a very important way to make a great pain coach.
Yeah, I agree. I think there have to be, yes, especially the people person bit to it. If you can teach someone theory and pain science, right, and they can understand it, or they can demonstrate they can understand it. They can learn the skills. I look at what I do and I think, is what I do, as in the treatments I suggest or the plans, is that particularly complex compared to other healthcare professionals? No, it's not. It's not like intricate surgery, perhaps. But the hard bit, which I think is what separates in our line of field and others, is the ability to, yes, manage the person in front of you and not be the hero, if you will, not to put them in. People always about put the patient in the driver's seat, right?
Exactly.
Them in charge, which some people find hard to let go, and they don't want to have that identity as a clinician, and that's fine. But I can teach the pain bit. I can teach the treatment bit. It's the person skills bit, really, that is the key. And you can apply that not just for managing people with persistent pain. You can apply that to other long-term conditions as well. You can learn, but it's the ability to roll with the person in front of you, as you say. I think that's really the key part. And for some people, that comes naturally. Some people you can learn it, as we'll be going through today. But I know there's other people that find it really hard, and it's just not for them, and that's fine.
And it's also about you figuring out if it's what do you think is professional. I think, and if I'm a professional, I need to put aside my human side. So we put on a cap that's different. And I think the ones who are able to more connect the professional and the personal side of it, not to be private, that's very fine line of difference, but still be very human. If we talk about George Engel, the biopsychosocial guy, we all know him. What he really wanted was, to humanize healthcare, right?
Mm.
So the humanizing thing about really meeting people, human beings, and seeing how can I actually understand how are you and how are your world and how do you see it? Like, what are your glasses look like? If I put on your glasses, what does it look like? And what is standing in the way of that? Yeah.
Yeah, what's their future? Yeah, not just the present, but the future as well. That's why I like that. The next bonus content is from my discussion with Tom Jacobs about how we could get buy-in for injury prevention programs with young athletes and coaches. And in this bonus content, we're discussing what an injury prevention warm-up or program would look like in a professional sports team, what unique and questionable injury prevention routines Tom may have seen, and is there still a role for screening for injury prevention with athletes? The first thing is, if I were to go and see a professional football team right now, let's say Liverpool, because you support them, and we were to see their injury prevention warm-up in action, what would I see?
Good question. I've not gone and watched them recently, but I can imagine that you'd have an S&C coach leading the warm-up, maybe a physio, or maybe it had been written by the physio and S&C coach together. I reckon it would involve a lot of like discrete movements that are football specific.
Yeah.
It would probably involve the ball a fair amount if the coaches have anything to do with it. They love it when you've got a ball in there. And I think it would probably involve a lot of jumping, changing direction, probably muscle activation. So it's like static, isometric contractions and functional movements, probably some perturbations or like jumping and banging against each other in the air, that kind of thing.
A lot of variety. I used to do injury prevention, had some ideas because I used to work in sport a few years ago.
Oh, did you?
Yeah, mine was martial arts. So my main sport is judo. So I did sport physio for a local, I guess you could put them at county level, or we'll say county level judo squad for that part of the country, and also for an MMA gym that was near where I lived as well.
Interesting.
So that's I haven't done that for at least 5 years, if not more. Family life happened and realized I preferred pain instead.
And what was your role kind of in those things?
So it's, at this time, physios in football, rugby was obviously established.
Right.
But unless you were professional / Olympic level, physios in those was still a fairly new thing.
Yeah, sure.
Especially MMA only came about, I think it was in the 90s. So I was there basically treating problems with the athletes as they came up. And we set up, thankfully I had a supportive coach on the judo squad who was very keen to get an injury prevention regime going.
Right.
So we developed one for the athletes. They were all in the adolescent range of late teens / early 20s. So either before or in uni squads. So I did that for a few years. It was good. And I always recommend it to people. Anyone that has an MSK interest, just give sport a go. Even if it's not something you do in the long term, I think there are things I learned from that and took from that. Just seeing injuries fresh when it happened, dealing with different people. Athletes have a different...
they're a different crowd, aren't they?
Yeah, especially ones that like to beat up each other. And coaches as well.
They're a particular breed.
Yeah. And it's just, I always recommend it, even if they don't want to do it long term. It's just wide, like we do rotations in NHS, right? Or whatever professionality it is. It's kind of one that I always suggest people just give it a go. You might not like it, want to do it long term, but it just opens your eyes a bit. I certainly felt it helped my career for the few years that I did it. Anyway.
Yeah. But you were there really in a like assessing treating injuries capacity, but also you brought some injury prevention kind of ideas to the table as well, right?
That's right. With the judo athletes, they actually had an app they could track them with or monitor them with. I'm sure like they have in the Premier League and stuff like that. Wouldn't be as fancy as that, but they would try to get them to record their intensity or perceived intensity of the session, how they were feeling that day, levels of sleep, etc. Getting the athletes to fill it out was a different challenge in itself, because it's not like on the football pitch where you can almost, or after training, almost force them to do it, I presume, at times. But with our athletes, because they were only being seen by the coach or me, maybe me once a week, if that, the coach maybe twice a week, they had more chance to evade it, so to speak, or forget about it. But I still enjoyed it. The other thing is, because I do those sports, if I didn't have to assess anyone or treat anyone or discuss anything, I could then go train.
Yeah.
Which was quite fun. The other thing I want to ask before we get into the main spiel of this, you've obviously seen a fair amount of injury prevention regimes over time. And you can think about this if you need to. What are some of the more questionable injury prevention regimes you've seen? Ones that make you go, is that really right?
Yeah, so this is a very interesting question. There's been, I don't know if there are questionable regimes, because you've either got evidence behind something or you don't, in my opinion. I guess I see it in a fairly black and white way when it concerns injury prevention programs. And I think that's kind of part of being a scientist, I guess, is that obviously you're a clinician, so you have to interpret scientific evidence as much as there is, along with other factors, to come to a useful conclusion or distill down that information in a useful way to the end user, so the athlete or the patient or the coach or whoever, or the parent. So I don't know if I can come up with sort of bad examples of injury prevention programs, but I guess in terms of the rationale behind the injury prevention, people have approached it from different angles over the years. In the Netherlands, and I'm not saying this is wrong, but in the Netherlands for a time, there was a quite widespread adoption of screening. So like trying to find the right type of person, or the type of body type, or the movement pattern that was most at risk of injury, and then working intensively with those people. So they would do like hop tests, jump down tests off a box, and how someone landed, if it fitted a certain movement pattern, then they say, oh, you're high risk for injury. You go and do extra training, or you go and do lots of extra conditioning because of. So, and actually more up-to-date research is suggesting that perhaps isn't the case. And it's more nuanced and it's more complex than we originally thought. And just because you've got a higher Q angle and your knee deviates further into valgus naturally because of your morphology, you're not necessarily, the more at-risk patient group or the more at-risk demographic. So I think we are in a period of probably in flux in the data, and I think when the paradigm isn't clear, it's quite easy for people to fall into one ditch or another, or it's human nature to want absolutes. So people will tend to kind of go, well, I believe this, or we should be doing this. No, it's not so cool to say, oh, well, we think this is the right way, but we're not sure. It's very hard for people to get behind that. Yeah. Whereas as a pragmatist, I feel that sometimes that is the honest truth. The temptation to jump down one particular approach and say this is the only way is always going to be there. But I think if we're trying to improve how things are done in sport, in this case in sport, then we need to have that open-minded skepticism. I like to call it curious skepticism or open-minded skepticism, because skepticism in and of itself can just be a very sort of negative way of viewing everything. It's, oh, it doesn't meet my threshold for credibility, so therefore it's not useful. And we shouldn't be doing that in sport. We shouldn't be doing that in physiotherapy, because I don't feel that there's enough evidence behind it. And then if more evidence comes out, then we suddenly have to backtrack and change our viewpoint. Whereas if we'd kept a little bit more open-minded, then perhaps there would have been more room and more curiosity for finding out other people's opinions, or learning from softer evidence rather than relying only on when a big high quality randomized controlled trial comes out, which, let's be honest, isn't that often for some of these things which are hard to study. So I guess that's a long and winding way of saying that things like screening normal, screening population groups for movement patterns in relation to, I think we mean in relation to ACL injury risk, is not such the done thing anymore. But it was done for a time in certain countries, and I think the world has moved away a little bit more from that now.
As we're on the subject, actually, is there any role for screening now?
Well, it's being done. I mean, it's being done in elite sport all the time, and that's really where this role of S&C coaches has evolved for, partly, is data. Getting data on people, performance testing, strength testing, people wearing these trackers to see what their cardiovascular fitness is like, and everything is measured in elite sport. And because I'm not of an elite sport background, it's hard for me to comment with much authority on that. But I think there's a fair amount of screening that goes on. It's perhaps some of it more useful than others. But there's also, I think, in the technological age in which we live, there's also an anticipation from people, whether they're athletes or whether they're weekend warriors, or even just people who don't participate in sport, is seeing data and 10% of this, and now it's 80% or whatever, is much more of an attractive thing. Relying on someone's opinion because they're a professional is still seen as valid, but people like objectivity and empirical information much more these days, I think, than perhaps going and, it's a little bit like it's how things have evolved with general practice, for example, or with a surgeon. You'd go and you'd ask your doctor what they think, and they tell you this, and they, oh, of course that must be right because they're my doctor. But that information revolution that we've been going through now for some time has meant that the world has changed. So I think screening is cooler than it used to be. It's expected more than it used to be. And I think some of it can be useful.
Right. Yeah. And finally, I'm going to leave you with some bonus content from my conversation with Matt Phillips, where we talked about how to speak with runners and difficult conversations with them. And in this bonus content, we're discussing what are some of the least popular running events. Thank you for listening or watching, and I'll speak to you next time. If I was to try and enter any running race at any distance, whether it's Olympics or non-Olympic running, which do you think has the least amount of competition that I'm most likely to succeed in?
How do I avoid the answer? It depends.
Say it depends.
It's like bingo a number of times. I say it depends, but oh, it does depend. It depends. The common, whatever distance you're running, the most important thing is to set out at a pace which you're going to be able to maintain for that distance.
Yeah.
And that's regardless of whether you're doing a 5K park run or doing a marathon. As long as you've got the discipline and your body is used to running at that pace for the required period of time,
Yeah.
then you should be fine.
Okay.
So yeah, there you go. There's your question. There's your answer.
Are there any particularly unpopular distances, or
Okay, it depends what your goal is. I mean, in terms of challenging, the 10K is often seen as a very challenging race because of the energy systems involved. And essentially, you're doing a 5K at that speed, but then you're doing it again, which sounds like, how did they do that? But they do. So I think that in terms of if you're highly competitive is seen as a really difficult race and not that popular. But no, it's all about preparation. Marathon takes lifestyle changes.
Yeah.
A lot of people do half marathon without too much of a change, but for a marathon, unless you're planning on walking it in like 7 hours or 8 hours, if you want to get a reasonable time and feel good at the end, that takes 12 to 16 weeks of lifestyle changes of nutrition and discipline and sleep and letting people know, loved ones, you're not going to be very sociable for that time.
You know what I was thinking of?
Go on.
Steeplechase. When was the last time you met someone who runs the steeplechase?
Not for a while now.
Yeah, like I can't think of. Everyone does marathons. Everyone does, or a few do Ironmans. People do their Ks of 5 or 10. But I can't think of a famous person that's ever done steeplechase. I can't imagine it
This is
being
true.
an
It's a
overly
good point.
competitive one.
Yeah.
Wonder if it's a chance where, not that I'm going to do it, but if someone fancy their chances, is it 3K, I think, for a steeplechase, or 5? I can't remember.
Yeah, I mean, as you say, don't think I've worked with anybody for a long time who's even mentioned that. So it's interesting you should bring it up. I'd go for it. It's
As
obviously
long
on
as you
your
can
mind.
jump a hurdle twice a lap,
Yeah.
and don't mind some soggy feet, then be fine.
It's interesting with the hurdles because I've got a reputation of kind of reminding people that stretching isn't as useful as people think for running because you don't really need much more range of mobility than if you're walking. You really don't need that much hip extension or anything or hamstring flex. We need a bit more hamstring. But when it comes to hurdles and stuff, you do. Suddenly the stretching is important. So you can do your swan poses and all your kind of yoga stuff. So it's almost like it's not running anymore because you do enter a new range of motion. But yeah, I'll support you. Go for it. I'll sponsor you.